Hi, welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this dermatology series, where we're breaking down essential topics for primary care practice and PANCE preparation. Today we're tackling squamous cell carcinoma, the second most common skin cancer. We'll cover what you need to know to recognize and provide general management of squamous cell carcinoma from a primary care perspective. Let's dive right in. Let's start off with a little bit of pathophysiology. Squamous cell carcinoma originates from the keratinocytes in the epidermis. Chronic exposure to UV radiation is the primary driver of this malignancy. This damages DNA, initiating a series of changes that can result in malignant transformation. Other risk factors include immunosuppression, chronic wounds, exposure to chemical carcinogens, smoking, and infection with high-risk human papillomavirus, which is HPV. While it's less common than basal cell carcinoma, squamous cell carcinoma has a higher potential for local invasion and metastasis. Now, who's at risk? Squamous cell carcinoma predominantly affects individuals with fair skin, particularly those who have significant cumulative sun exposure. It's more common in older adults, specifically men, and immunosuppressed individuals such as organ transplant recipients. As far as clinical presentation, the classic lesions of squamous cell carcinoma present as hyperkeratotic, firm papules, plaques, or nodules that may be ulcerated. The lesions may bleed with minimal trauma and then crust. They're most often found on sun-exposed areas like the face, neck, ears, forearms, and dorsum of the hands. It is also important to be familiar with squamous cell carcinoma in situ, which is also called Bowen's disease. This is when it is confined to the epidermis and has not invaded past the dermal-epidermal junction. These appear as an erythematous patch or thin plaque with a scaly or rough surface. The diagnosis of squamous cell carcinoma starts with clinical suspicion. Dermoscopy can assist, however, definitive diagnosis requires a biopsy such as shave, punch, or excisional. Histopathologic examination is also useful to assess for perineural invasion, tumor differentiation, and tumor depth, which are factors that are important for tumor staging and prognosis. Now, let's talk about the management. The management depends on the lesion size, location, depth, and histologic features. For low-risk lesions, standard excision with 4 to 6 millimeter margins is generally recommended. However, Mohs surgery can be used if there is concern that standard excision would result in a poor cosmetic or functional outcome. Prevention is a cornerstone of managing squamous cell carcinoma. Encourage your patients to wear broad-spectrum sunscreen, seek shade, and wear protective clothing. Routine skin checks are essential for high-risk patients, especially those with a history of squamous cell carcinoma or actinic keratosis, which can be a precursor to squamous cell carcinoma. Now, here are some pearls to remember. Number 1. Lesions on the lip, ear, and periungual areas are more aggressive. Suspicious lesions in these areas should always be referred for biopsy. Number 2. Signs that squamous cell carcinoma in situ has progressed to invasive squamous cell carcinoma are nodule formation within the plaque and onset of pain or tenderness to the lesion. These are important factors to monitor for. And number 3, regular follow-up is critical for early detection of recurrence or new primary lesions. All right, let's test ourselves with some clinical questions. Question 1. A 72-year-old man presents to your primary care clinic with a non-healing ulcer on his left ear that has been present for 3 months. He denies pain but reports occasional bleeding. He has a history of significant sun exposure as a farmer. Examination reveals a 1.5 centimeter indurated lesion with ulceration and crusting. No regional lymphadenopathy is noted. Which of the following is the next best step in management? Is it A, cryotherapy, B, observation with follow-up in 6 months, C, biopsy of the lesion, or D, start topical 5-fluorouracil? I'll give you a couple of seconds. If you chose C, biopsy of the lesion, you are correct. The clinical features are highly suspicious for squamous cell carcinoma. Biopsy is necessary to confirm the diagnosis and guide appropriate management. Question 2. A 55-year-old woman presents with a small bump to her forearm that she noticed 4 months ago. She reports a history of actinic keratosis in the same area which was treated with cryotherapy 2 years ago. She denies pain or bleeding. Exam reveals a 2 centimeter well-defined erythematous hyperkeratotic scaly indurated plaque. No lymphadenopathy is noted. Biopsy confirms squamous cell carcinoma. Which of the following is the most appropriate management for this lesion? Is it A, standard excision with 4 to 6 millimeter margins, B, cryotherapy, C, topical imiquimod, or D, observation with follow-up in 3 months? If you chose A, standard excision with 4 to 6 millimeter margins, you are correct. Surgical excision rather than destructive treatments is the general recommendation for most patients with low-risk squamous cell carcinoma. Great job! Thank you for tuning in to this episode of the Pro-PA podcast. Squamous cell carcinoma is a significant condition in primary care, but with early recognition and management, you can make a big impact on patient outcomes. Don't forget to subscribe and turn on notifications so you don't miss our next episode on melanoma. And as always, this is the Pro-PA podcast, where future pros in medicine are made. See you next time.